Welcome back to the deep dive. Usually when we talk about front lines in medicine, you picture a battlefield, maybe a sterile operating room. But today, we're heading to a different kind of front line. The one with, the fluorescent lights that hum 24/7, the waiting rooms are overflowing, and those sliding glass doors just never stop opening. We're talking about the emergency department.
It really is the absolute front door of the American healthcare system. And for a specific group of people, those dealing with opioid use disorder, or OUD, it is often the only door they ever knock on.
That's the setting. It's high stakes, it's chaotic, and frankly, it's an incredibly difficult place to start a long-term recovery journey.
It really is.
But that's exactly what we're analyzing today. We're looking at a huge multi-site clinical trial that just dropped in JAMA on February 11th. It's called the ED Innovation Study.
And the name is pretty appropriate because it's testing a very specific innovation. It's trying to answer a question that it's plagued addiction medicine for years. We know how to treat the withdrawal chemically, we have the meds, but how do we solve the logistics?
Exactly. Because getting a patient started on medication like buprenorphine, it saves lives. That part is established science. The problem is keeping them on it once they walk out of the hospital and, back into the real world.
Retention is the holy grail here. You can do everything right in the ER, stabilize them, treat them with respect, get the medication in their system. But once they leave, that chain of care is just so fragile.
So fragile.
They have to find a pharmacy, they have to pay for the script, they have to remember to take a pill or a film every single morning. There are a million places for that process to just break down.
So this study asks, what if we could remove that daily burden? What if, right there in the ER, you could give a patient a single shot that essentially locks in their treatment for an entire week?
It's sort of the set it and forget it hypothesis. The idea is to bridge that gap. Instead of relying on the patient's willpower or, executive function during that first incredibly difficult week of recovery, you let the pharmacology do the heavy lifting.
And we are going to unpack whether or not that actually works. And the answer, spoiler alert, is complicated. But before we get to the winners and losers, let's talk about the scope here. This isn't some small pilot program.
No, this is a heavyweight study. We're looking at data from 29 different emergency departments all across the U.S. They enrolled roughly 2,000 patients. And the timeline, that's crucial context. The data was collected from July 2020 all the way through August 2024.
Which means this study was running right through the absolute peak of the fentanyl crisis.
Exactly. And that's going to be a major theme here. This data reflects the reality of the street right now, not the reality of, say, 10 years ago.
Okay, so let's set the stage with the contestants.
Right.
In one corner, we have the standard of care. This is what usually happens if you're lucky enough to be in an ER that treats addiction aggressively.
Right. So this is sublingual buprenorphine. It's usually a film or a tablet that dissolves under your tongue. In this study, if a patient came in with withdrawal, they got a dose right there in the ED to feel better. Then they were discharged with a prescription for 7 days, typically around 16 milligrams a day.
So the burden is just.
Yep.
It's transferred to the patient. Here's your script. Go fill it. Take it tomorrow.
Correct. It requires active participation from the patient every single day.
And in the other corner, the challenger,
Mm-hmm.
the extended release injection.
This is a formulation called XR-BUP. It's a 24 milligram injection given subcutaneously, so just under the skin of the abdomen or the arm right there in the ED. It forms a little depot, like a gel reservoir, that releases the medication slowly and consistently over 7 days.
The logic there seems incredibly sound. I mean, if I'm struggling with addiction, my life might be chaotic. I might not have a car to get to the pharmacy. I might lose the pills.
Or sell the pill.
Or sell the pills. With the shot, the medicine is in me. I'm treated for 7 days, whether I like it or not.
That's the theory. It just removes all that friction. It buys the patient a week of stability where they don't have to wake up and make a choice to stay sober. That choice was sort of made for them a week ago.
So before we reveal if that theory held up, I want to talk about the people in this study. Because 2,000 patients, it's a sterile number. Who are we actually talking about?
Yeah, the demographic snapshot is so important here. Median age was 37. About 68% were male. But the statistic that really defines this cohort, and frankly defines the modern opioid crisis, is the fentanyl positivity rate.
I saw that in the data tables, 76%.
76%. 3/4 of the patients tested positive for fentanyl. And honestly, given the limits of some screening tests, the real number might even be higher. We're operating in a completely fentanyl-saturated environment.
So for the listener who hears fentanyl on the news but doesn't really know the pharmacology, why does that 76% number matter so much for a study like this? Why is it different than if they were on heroin or oxycodone?
Oh, it changes the game completely. Fentanyl is incredibly potent. I mean, 50 to 100 times stronger than morphine. But more importantly for treatment, it's highly lipophilic.
Meaning what?
It means it stores in the body's fat cells and it sort of leaches out slowly over time.
So it lingers.
It lingers, and that complicates the whole withdrawal timeline. With heroin, withdrawal hits you fast and it leaves fast. With fentanyl, it can be this jagged, unpredictable process. And because tolerance is so high, patients need higher doses of medication just to feel normal. These people in the study weren't just using drugs, they were battling a very potent, very sticky chemical dependence.
And to even get into this study, they had to be in withdrawal, right?
Yes. They used what's called the COWS scale, the clinical opiate withdrawal scale. Patients had to score a 4 or higher.
And what does a 4 look like? I mean, what does that feel like?
A 4 is mild to moderate. You might be sweating a little. Maybe your pulse is elevated. You feel anxious, restless legs, maybe some goosebumps. You are definitely not feeling good. You're in that window where your body is just screaming for opioids.
Okay, so we've got 2,000 patients, mostly on fentanyl, feeling sick in the ER. Half get the pills in a script, half get the 7-day shot. The primary goal was engagement in treatment at day 7. Basically, did they make it to their follow-up appointment?
That's the finish line for this specific race. Did they bridge that gap from the ER to the outpatient clinic?
I think most people, myself included, would bet on the shot. It just seems obvious.
It does seem obvious, but this is why we do the science.
So what happened?
It was a wash.
A wash.
Effectively a tie. In the extended release injection group, the engagement rate at day 7 was 40.5%.
Okay. And the pill group?
38.5%.
That is, wow, that is barely a difference at all.
The adjusted difference was 1.6%. Statistically, there was no detected difference. The fancy, expensive, guaranteed injection did not result in significantly more people showing up to their follow-up appointment than the standard paper prescription.
That is baffling to me. If the medicine is working, and we have to assume it is, why did the shot group show up more? They didn't have to deal with a pharmacy. They should have been more stable.
It really challenges our assumptions about why people drop out of treatment. We tend to think, oh, if we just fix the withdrawal, they'll engage. But this data suggests that biological stabilization is it's not enough on its own.
It's the system, isn't it?
It has to be. I mean, you can have perfect brain chemistry, but if you don't have a ride to the clinic or you don't have a phone to confirm the appointment, or you're homeless and worrying about where you're going to sleep tonight, that clinic appointment just falls down the priority list.
And looking at the 30-day numbers, it didn't get any better.
No. In fact, at 30 days, the pill group was technically, though not significantly higher, 44.9% versus 43.8%.
Wow.
So nearly 60% of patients in both groups had dropped out of care within a month.
That is a sobering statistic. It tells us that the medication, whether it's a shot or a pill, is only one piece of a very, very broken puzzle.
Precisely. The better mousetrap didn't catch more mice because the problem wasn't the trap, it was the whole environment.
However, and this is a big however, we shouldn't throw the baby out with the bathwater here. Because when you look past that one retention number, the study reveals some really fascinating differences in how the patients actually felt.
This is critical. We call these secondary outcomes. But for the human being in that hospital bed, these are the primary outcomes. This is their life.
Let's talk about the craving scores.
So they measured cravings on a scale of 0 to 100. At day 7, the patients who got the shot reported significantly lower mean craving scores compared to the pill group.
Okay, give us the numbers.
The mean was 26.5 for the injection group versus 30.2 for the sublingual group.
4 points. Is that meaningful?
In addiction medicine, oh, absolutely. Cravings aren't just, oh, I want something. They are a pervasive, intrusive noise. It's like a radio in your head that you can't turn off. Turning that volume down by even 10 or 15% can be the difference between a white-knuckle struggle and actually having the mental bandwidth to think.
And that mental bandwidth translated into behavior, right?
Okay.
Because they also tracked illicit use.
They did, and this is a major win for the injection. The group that got the shot had significantly fewer days of illicit opioid use during that first week.
So they were using less fentanyl.
Significantly less. The adjusted ratio of means was 0.77. That indicates a real reduction. So think about it. Even if they didn't show up to their appointment at a higher rate, their week was safer. They bought fewer drugs, they injected fewer times, they were less exposed to all the dangers of the street.
And they reported higher satisfaction.
Yes. They preferred the shot. They liked not having the Bailey reminder of their disease. They liked the stability.
So if I can summarize, the injection didn't fix the systemic problem of retention,
No.
but it did provide a superior patient experience. It worked better as a medicine, even if it didn't work better as a system fix.
That's a perfect way to frame it. And for an ER doctor, that matters. If I can give you a week of lower cravings and less illicit use, that's a therapeutic victory, regardless of what happens next week.
Now, I want to pivot to what might be the most important part of this entire study for the medical community. We need to talk about fear.
Specifically, the fear of precipitated withdrawal.
We mentioned earlier that doctors are sometimes terrified to start buprenorphine in the ER, especially with fentanyl in the mix. Can you break down exactly why? What's the mechanics of this fear?
Sure. So buprenorphine is what we call a partial agonist with high affinity. Think of the opioid receptors in your brain like a parking lot. Fentanyl is like a Ferrari parked in every single spot, revving the engine at maximum volume. That's the high or the pain relief.
Okay, Ferrari in the parking lot, got it.
Buprenorphine is like a heavy-duty bulldog truck. It wants that parking spot, and it's stronger than the Ferrari. So if you introduce buprenorphine while the fentanyl is still there, the bulldog literally rips the Ferrari out of the spot and parks itself.
But the bulldog doesn't rev the engine.
Exactly. It parks, but it just idles quietly. So the brain goes from maximum revving to quiet idle in a split second. And that sudden drop in activity is precipitated withdrawal.
And that feels like what?
It's absolute misery, instant severe withdrawal, vomiting, diarrhea, shaking, panic, pain. It's traumatic. And once a patient experiences that, they're often terrified to ever try medication again.
And the prevailing wisdom, or maybe the prevailing anxiety, has been that because fentanyl sticks around in the body for so long, the risk of this crash is incredibly high.
Yeah.
So doctors have been tiptoeing around treatment.
Right. They wait too long, or they give these tiny microdoses, or they just refer the patient out because they don't want to risk causing that reaction in a busy ER.
So here we have a study with 2,000 high-risk patients, 76% on fentanyl. Did the injection cause mass precipitated withdrawal?
No. And this is the headline. The rate was incredibly surprisingly low.
How low?
In the injection group, 0.6%. That is 6 people out of roughly 1,000.
Less than 1%.
And in the pill group, it was 0.8%, also less than 1%.
That basically destroys the argument that we need to be so afraid of this.
It really does. It turns out that the fear of precipitated withdrawal is vastly larger than the actual risk, provided you follow the protocol.
And the protocol was just wait until they are in mild withdrawal.
That's it. A COWS score of 4. If the patient is already feeling a little crummy, meaning the Ferraris are already starting to leave the parking lot on their own, it's safe to bring in the bulldogs. You don't need to wait until they're in agony.
This feels like a massive green light for emergency departments across the country.
It is a massive green light. It removes the hesitation. It tells doctors, you can treat this. You can use standard doses. You can use the injection. And you can do it safely, even in the age of fentanyl.
Did they see any difference in overdose rates? Because that's the other big fear.
No difference. Overdose events within 30 days occurred in 18 participants in each group. So that's about 2.3%.
Which is tragically high.
It is. 1 in 50 patients overdosed within a month. I mean, that highlights the urgency of this disease. But it also confirms that the type of buprenorphine shot or pill didn't change that risk. The risk is the disease itself, not the treatment.
So let's zoom out and try to synthesize all this. We started with a question. Is the 7-day shot a game changer?
And the answer is, it's nuanced. If you define game changer as solving the dropout crisis, then no, it's not magic. It doesn't fix the broken bridges in our healthcare system. But if you define game changer as providing a better, more humane patient experience and giving doctors a powerful new tool, then yes. Absolutely.
It seems like it's about having options in the toolkit.
Exactly. Medicine shouldn't be one size fits all. For a patient who is organized, has a home, and is motivated, the pills might be fine. But for the patient who is chaotic, homeless, or just exhausted by the daily grind of addiction, that shot is a gift.
It buys them a week.
It buys them clarity, it lowers the noise in their head, and as we saw, it keeps them safer from street drugs for those 7 days. That is absolutely worth doing.
And the safety data basically removes the excuse for inaction.
That's the biggest takeaway for the medical community. We can stop being afraid of the fentanyl interaction. The data is in, it's safe.
I want to end on a thought about that handoff. We saw that 60% of people dropped out, regardless of the treatment.
It's the elephant in the room.
We have spent billions developing better molecules. The chemistry is good, the pharmacology is solid, but the logistics are still failing.
Which suggests that the next big breakthrough in addiction medicine, it's not going to come from a lab. It's going to come from policy. It's going to come from figuring out how to physically get a human being from the ER to the clinic without them falling through the cracks.
Peer navigators, transportation, housing.
Exactly. We've optimized the drug. Now we need to optimize the care.
Well, that gives us plenty to think about, and probably a topic for a future deep dive on healthcare systems.
I would look forward to that.
For now, we'll leave it there. A fascinating look at how data can surprise us, and how even a failed primary outcome can teach us how to save lives. Thanks for listening.
Stay curious.